The Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between. Pediatric Executive Development System, or PEDS, is a dynamic, transformative program designed to accelerate the growth and development of the leaders in the field of pediatric entrepreneurship. PEDS takes a hands-on approach to problem solving, addressing real-time situations within your organization. More than a theoretical course, it is a practical platform that accelerates learning. Look at our link on the show notes for more information. Hey, George, good morning. It's Tuesday morning. I'm in Baltimore at Sinai Hospital with a good friend of ours, Dr. Scott Krugman.
Yeah, welcome back, Dr. Bravo, from your hiatus from the podcast. He was working as a general pediatrician for a month. Cannot do two things at one time, so he took off. But now we're back with a great guest, Dr. Scott Krugman, and his topic is going to be a grandson's memories of a genius physician and the closing of a pediatric service lines for profit, the good old dollar. Take it away.
So, Dr. Krugman, welcome to the show.
Thank you for having me. It's an honor to be here.
Thank you. Thanks for having me at your children's hospital here at Sinai Children's in Baltimore. Dr. Scott Krugman is the grandson of a legendary and genius pediatrician whose book I hold close and near to my heart all the time. And if you've seen the show once, you have seen the book at least once. And I'm going to get schooled a little bit, but if you're on the video, this is my Bible. And then I want to show you something different. This is a different edition, and this is Dr. Scott's, but his is autographed. Mine is not autographed. And Scott is the vice chair of pediatrics here, and he's a pediatric child abuse expert too. Scott has a very interesting history. He shared some time in Costa Rica, where I did medical school. And then he went to school with Chip Hart.
I went to college with Chip Hart, the great Chip before he was the great Chip in pediatrics.
And I am sure you have some good stories you'll tell us later in the podcast about what it was like to be with Chip Hart when he was a young man.
I can only give a few, but he made a good choice and married one of my good friends. So he had some decision-making capacity back then.
So he was intelligent back then.
He came off across that way.
Wow. Then you went to medical school at the University of Maryland.
Dartmouth Medical School.
Dartmouth. Okay.
Yes.
And then you ended up at Hopkins.
I came to Hopkins for residency. I planned to be in Baltimore for 3 years, and that was 30 years ago.
It was a wife that kept you here? Or?
No, it was just Baltimore. I got a great job afterwards and keep having great connections and opportunities, so never left.
I know Hopkins is one of the premier residency programs in the country, but when your grandfather is an eminence in pediatrics, why do you choose Hopkins over CHOPS, over Cincinnati?
Yeah, so it was interesting. I think there's a couple important things about being what I am now, a third generation pediatrician. My dad grew up in New York with my grandfather, ended up going to medical school at NYU, and then left residency and went to Colorado. So I was born and raised in Colorado, and my dad became a prominent pediatrician in Colorado. So I left and I came to the East and I never went back. So we both stayed away from our elders to some extent. I liked Hopkins. I did rank CHOP and Cincinnati, like both of them very much, but ranked Hopkins first, mostly because of the people. And one of the great people I interviewed with was Dr. Peter Rowe, who does a lot of the chronic fatigue work now and is just, if I'm smart, he's uber smart. He was incredible. That really brought me there. And we had a great class. And unlike most classes that go through Hopkins, my residency year, most of us went as general pediatrics.
Oh, well, and Catherine DeAngelis and Oski were there at that time?
Frank had just died. I missed him. Kathy DeAngelis was transitioning to Chicago, but Janet Serwent was there and she was fantastic. And there were a lot of great mentors and it was a great program.
It's a powerhouse. It's been a powerhouse for 50 years plus.
Yeah, for sure.
And other than your father and your grandfather being pediatricians, Why did you become a pediatrician?
I think, according to my mom, when I was 6, I decided to be a pediatrician. I'm not sure if I remember that, but at least in high school, I definitely liked sciences. I liked doing community service work and figured, oh, this is cool. I could do this. And I really was attracted to speaking Spanish. So did a summer abroad program in Costa Rica where we spent a month down there at the school. And after that became pretty fluent and decided this makes sense. I'm going to be a Spanish speaking doctor.
Oh, wow. Wow. There's a lot of Spanish speaking people in Denver.
There are, and there were back then. And when I was very young and lived in Denver City, we got bused. So I was bused from my neighborhood to a predominantly Spanish speaking neighborhood.
What was Lakewood?
It wasn't Lakewood. It was within the city at that point, but it was a long time ago.
That's a long time. Wow. And who is
It's Richard.
Richard or Dick Krugman?
Dick Krugman, my dad, he is today's his birthday. He's 81.
Happy birthday.
He is still kicking around, which is amazing. He became head of the Kemp Center for Child Abuse when I was in high school. Most people you're at dinner having your stories. His were talking about, oh, this child was abused and this child was this. I'm like, are you kidding me? This is what we're growing up with? But it made an impression clearly because it clearly made the impact that this was important and somebody needed to do this work. And then after I left and was in college, he became dean of the medical school, and he was dean at the University of Colorado for 24 years.
Yeah, he had a long tenure, one of the longest tenured deans of a medical school, right?
He got the Iron Man award. They actually gave him a little Iron Man figurine because he was dean for so long. And then he eventually stepped down, and now he started a foundation to end child abuse and neglect with one of his former patients, Lori Poland, who was abducted at the age of 3 and was treated at the Kemp Center in the early 80s.
Oh, wow.
So it's an amazing story. Giving Tuesday, feel free to look up NCAN and support them. Yep.
NCAN.org?
Yep.
Okay. We'll put that in the show notes where people can give.
Yeah.
And then
your grandfather, right?
Yeah. So I know about your father from Dan Fighton. And Dan Fighton was a pediatrician. He lives just at the south side of the city near the University of Denver.
Okay.
And he's now the CMO at Office Practicum. And when I told him I was going to interview you, he said, I know the guy. I said, no, I think it's his son. He says he was dean at the school, and then he, for a short stint, was acting chairman at the Children's Hospital.
Yep.
And he's phenomenal. I'm like, no, I think I'm interviewing his son.
Well, that reminds me of the story where I met Ozzy Taub, who was a great adolescent doctor here at Sinai for 30 years. It was my first Pediatric Academic Societies meeting in 1999. I think it was in Baltimore. We got on the elevator, and he looks at my name tag, Krugman. I know your father at NYU. I'm like, grandfather. He's, I feel very old. So it's the same type of thing.
And then who was your grandfather?
So Saul was my grandfather. We grew up in Denver, obviously far away from New York, but would come out pretty regularly. And every summer, my parents would leave us with my grandparents, and they'd take us up to Jewish summer camp. So I went to Jewish summer camp in the Poconos for many years. And sometimes my grandfather was already there because he was the camp doctor. Sometimes he'd drive us up in his very bad driving. Other times, random pediatricians from Long Island would take me up and give me stories. Oh, your grandfather this, your grandfather that. And it turns out this summer camp was a breeding ground for doctors. So all the workers would get to know my grandfather, and he'd get him into NYU. So Bill Borkowski, who's a fantastic Peds ID doc, ended up at NYU, came from the camp. He was a camp worker. So,
oh, wow.
There's some crazy stories about Camp Equinox.
And your dad had a phenomenal career, right? He was the son of Russian immigrants.
My grandfather, yes. So he grew up in Paterson, New Jersey, and his cousin was Albert Sabin, who is famous for polio vaccine. And they both worked very hard to try to make it. And he really struggled to get a pediatric residency. So he did a general residency, then got sent to the World War II and was a flight surgeon over the Pacific for a couple of years. There's a log of the thousands and thousands of miles. He went from island to island, bringing patients back to the dispensary where they'd set up each one. And after that, he really wasn't even offered a position at NYU. He just got to know Dr. Bob Ward, and eventually they're like, okay, we'll hire you, and worked his way up to being chair of the department. And I think he feels like those years when he was chair were the worst years of his life. And he couldn't understand why my dad wanted to be a dean, because his administration's awful. And
So he was really a clinician. He loved research and clinician.
he loved his lab. And everything I remember about visiting their apartment in NYU, which literally was across the street. They lived in Kips Bay, across the street from NYU. So he'd go down to the basement, walk across the street, go to his lab, and he'd spend as much time as possible in the lab. He'd come home, eat dinner, go back to his lab.
Oh, wow.
And he kept samples for years and years. So when HIV first came out, he had blood samples that were kept for years prior so they could go back and see, because he was doing hepatitis testing, if there was any linkages between people who had left their blood in the past and had HIV. So it was pretty unique how he worked his lab.
And he was instrumental. The key, the landmark was hepatitis B vaccine drawn from serum, as well as, I'm going to say VSIG, but it was immunoglobulin directed to hepatitis B virus. He discovered the virus, he isolated it, and then he created the immunoglobulin and the first vaccine, and worked with Maurice Hilleman at Merck to actually put it into production.
Yeah. So the initial studies were trying to figure out the difference between hepatitis A and hepatitis B. And they had different words for it back then, like serum hepatitis and enteric hepatitis, but he worked it out. And Dr. Blumberg in Australia had the antigen. They found the little hepatitis B antigen. He had the antibodies. So it was like they were matched together, and then they ended up figuring it all out. And he won. When I'd go visit, there's like all these awards everywhere. And my grandmother, of course, was the one who was like, her life revolved around him and everyone else. So she would like, here's the story about him, and here's this. And so it was a lot of stories we got about his past.
But he also was instrumental in the measles vaccine.
Yeah. So he was part of the original trial with Enders and cats where they tested the efficacy of the measles vaccine. So he was one of the sites, and they would they did the vaccine trial, they ran the blinded work, and then they showed that, wow, it really was effective.
And that was the one that was extremely toxic, the first vaccine or the second vaccine?
It was better. I think that was a better one that actually worked.
The one that worked?
The one.
Because the first one, they had to give you immunoglobulin along with the vaccine.
Been involved in that too, but he definitely did that original vaccine trial with Enders and cats.
And where was Enders? Cats was in Duke.
This was when they were both at Boston Children's. Okay. And then when Sam Katz finished, he ended up at Duke for many years.
And where was Enders? Was Enders at Boston?
He was in Boston.
Okay.
Yep.
All right. Yeah, phenomenal work, right? George has had measles.
Yep.
He loves the experience.
Oh, I'm sure. I had measles as an intern working in Jersey City in 1990. Wow. Can't think that far back. 1993. Look it up. There was an epidemic in Jersey City.
Yeah, that was the year before it came to 2 doses, right? That was one of the reasons it became that way.
No, the 2 doses came much earlier. I think I was of the generation that was forgotten. Could have had 2, got into kindergarten. So that's why the vaccines are important to go to school to prevent these things. You should write a story about this where I'm sick. I'm working in an emergency room, checking kids that have measles, admitting them, and probably spreading it.
Yikes.
And I ended up in the hospital for 2 weeks. So
wow.
It wasn't a easy childhood illness.
No.
When you're 29.
It's just amazing the things they did. Even 7. I don't know where they came up with these ideas.
Yeah.
But and sometimes they did it in their kitchens.
It's really interesting. I think from my grandfather's standpoint, he always was being asked to help figure out how to get this better, how to make this go away. And he loved that challenge of trying to figure out what's causing the illness and how to make it go away. And that was his passion for many years.
And other than the Jewish camp and the bad driving, what other, like before you were aware of who he really was, what are 1 or 2 endearing stories of just being a grandchild, seeing your grandpa coming home from work?
So it's fascinating because he had his routine. He loved his routines of come home, eat his dinner, sit in his relaxing chair and eat his cherry vanilla ice cream. It was always cherry vanilla. Why? But that's the only ice cream he ever ate.
He's worse than me.
He was completely, and there was never any variation. It was remarkable.
Oh, wow. Did he ever drag you into the lab as a young child?
Yeah, I went over a few times and got to see it. And then I was fortunate in college to have a summer where I worked with Dr. Borkowski and Krasinski in that ID division and did a little bit of research with measles and herpes and got to hang out with them in the HIV clinic, which was an amazing experience because it was 1990, 91, and there was still not a lot we were doing for HIV back then. And the numbers in New York were huge. So it was very impressionable at that point but at that point I had realization of, oh, this is a big deal, right?
Yes.
And you walk down NYU and there's the portraits of the chairs and, oh, there's Grandpa.
What an experience.
Yeah. So that was really cool.
What an experience. And then what is your fondest memory of Costa Rica? And just to set the scene. So Universidad de Costa Rica is in San Pedro.
Yep.
And to get to San Pedro is the main drag, and there's a big bridge. And right in that big bridge is ICE. ICE is not immigration, but Instituto Costarricense de Electricidad on the right. My dad's house was a half a block from that, overlooking the city. And so you made a left turn and went the other direction up to the university.
Yeah. So it was my junior year abroad. I was at Middlebury College, and the first semester I was in Spain at the Middlebury program in Madrid. So that was very fun. The second semester I was on the University of Kansas program at University of Costa Rica. So we lived with the family right in San Pedro there.
Okay.
I had a couple older brothers and a younger brother and a mom who was doting over us and everything. And there was probably about 20 of us American students in the program.
Oh, wow.
And I think the cool things were, one, we just went right into classes at University of Costa Rica. So I took art history, I took politics. It was just me and a bunch of Costa Rican students, which is really cool. We got credit for that, which is fantastic. But really what the most amazing thing was, we'd have the weekends free and we just travel everywhere. And this was pre-internet, Airbnb. We stayed in hostels. We took buses. We're with the chicken buses going to Montezuma, going up to Tortuga, trying to figure out how to get to the little hotel we were staying at. So it was an amazing experience to see that whole country over 6 months, because it takes 6 months to see the country, because it is the most beautiful and incredible place around. So
it absolutely. Did you ever get to go into the children's hospital by any chance?
I didn't, because I was, a college student. I was
so sad. It's such a beautiful place.
For sure.
It's such a beautiful place. So many great people there. And then we want to talk to you about your previous experience. You were the chairman of a hospital division
of pediatrics.
A pediatrics department, the community hospital in Baltimore.
Yep.
And that is owned by MedStar?
It's part of the MedStar system.
And how many years were you chairman at this hospital?
So part of the reason I stayed in Baltimore so long is right after residency, I got a job at Franklin Square, where the chair at the time had just arrived there from Vanderbilt. He was the division head of pediatrics at Vanderbilt, became chair at the community hospital. And he was an amazing guy, Mark Warner. And he ended up within 2 years of me joining. And really what he did was created a department. So at this hospital, there were community pediatricians that went around. We're talking old school, right? You'd see your patients, you'd round in the morning and then go to your patients in the afternoon. And there was a 18-bed pediatric unit sitting up on the third floor. And back in the 80s, that was pretty typical. The average length of stay was 3.5, 4 days. Kids would be there a long time. There'd be a lot of kids who just sit there with an appendix for 3 days, things like that. We started a program with 3 of us who became faculty, and then within a year developed a hospitalist program. So we were one of the early adopters of the hospitalist model in 1999. And within 2 years, our length of stay went down to 1.5. We stopped admitting kids who didn't need to be admitted. And now our average daily census is 3.
Yeah.
And they said, okay, you get 1 nurse. We're like, how you run a unit with 1 nurse, right? You can't do it, right? You can only run a unit. Maybe you can in the summer, but you can't in the winter. And it just didn't make any sense to have an 18-bed unit. So my chair became vice president of the hospital in 2002 and said, you're chair. So 4 years out of residency, I'm chair of pediatrics.
Oh, wow.
And I'm like, okay, I guess I better figure out how to do this. And I figured it out pretty quick. And I really had to figure out even faster because he was fired a year later. And then it was just me all by myself. My great division head of neonatology, Alan Bedrick, who's at Arizona now, was 15, 20 years my senior. And then he's reporting to me now. And I'm like,
Oh, wow.
figure this out. I'll be very supportive and we'll figure out how to make this work.
And so you had 17,000 visits in the ER, about 800 admissions a year.
So we had gone down at that point about 600 and said, we got to do something different. So what I did was give up our 18-bed unit and moved pediatrics next to the emergency room.
Okay.
And we put our hospitalists in the emergency room and had a unit that was both inpatient and ER.
Great.
And that model was unbelievably successful because then our ER visits went through the roof because we had a pediatric ER and there are pediatricians in the ER and everyone's, oh, we're getting good care.
Right.
Novel concept, right? And then at one point we peaked at 25,000 ER visits and 1,200 admissions, which was like after Hopkins, Maryland, Sinai, we were the next busiest pediatric inpatient unit.
Wow.
It started to go down a little bit in the mid 2010s because urgent cares popped up. Nobody was coming to ERs as much anymore. We were still doing 850 admissions. We had a fantastic unit. One side was the ER with 10 beds. The other side was the inpatient unit with 6 beds. The nursing staff floated back and forth. The doctors floated back and forth. It made a lot of sense. Award-winning program from the Academic Pediatrics Association. And we were doing great, I thought. And then we weren't.
Oh, wow. And
I'm curious for 1 second. Before you guys developed the hospitalist program, who managed the patients and how did they manage the patients?
Yeah. So it was like literally the community physician, they had a rounding schedule where they would rotate it. So one community doctor would be a Monday, another would be Tuesday, another would be Wednesday. And it was a mess, right? Because there was continuity.
Mm-hmm. And how about at nighttime?
They had the in-house doctor, which was a moonlighting fellow, a family physician, a random it was a random coverage system.
A second-year resident.
And a second-year resident. So often the most senior person with a sick kid was a second-year family medicine resident.
Yeah. That's how it used to be. When I was in Chicago, you could get your unrestricted license after your second year.
And then moonlight.
And then you went to the community hospitals and you got paid money for actually taking calls as opposed to taking call when you were working in your own residency program.
Right. But the community physicians were not paid for this job. It was
they were not.
Volunteers. Yet the hospital had to provide this service. Otherwise, it couldn't be a hospital.
That's hard to know, right? Because not every hospital does inpatient pediatrics, especially in Maryland.
Not anymore.
No, even back then, there were many hospitals that didn't do inpatient peds. And it's just been...
for example, Montgomery General has never done inpatient peds.
No.
Aldi. Never.
No.
They've never touched it.
And Good Samaritan never did pediatrics. The old Church Home Hospital never did. So there were different hospitals that would and wouldn't. But over the years, especially in this community, it's just been one fewer every couple of years. They've been going down and down.
And then when you read the papers about the closure at Franklin Square, there was little or no notice to anybody.
No, there was 3 days.
3 days, the whole thing is shut.
I walked in on a Tuesday and for my regular Tuesday meeting with the VPMA of the hospital, and she said, we're closing pediatrics on Friday. I said, you're doing what? And they literally closed the doors in 3 days without planning and taking contingency plans for a lot of different things. To child sexual abuse cases. We were the center for the county. The admissions for psychiatry, the surgeons, who's going to co-follow the patients.
How about the nurses?
30 nurses and 10 doctors later, it was closed.
And let's just set the bar. I'm not going to be partisan. I don't care about MedStar, Hopkins, or Inova, but MedStar is not losing money. I think the revenue is $68 billion a year with 10 hospitals.
So they have 10 hospitals, and this is was an ongoing effort to consolidate services so they wouldn't have duplicate services in different hospitals. And they just decided that they didn't want to do pediatrics in Baltimore. So they got out of pediatrics in Baltimore.
Well, very sad when I hear these stories. You guys
Yeah,
put in
and
a lot of
most-
work to develop it, and it was successful. I guess your success is what killed you.
I think it's hard to know. I think that even somewhere Tufts now is closing pediatrics. So this is a trend that Dan Rauch, who was at Tufts, ironically, he and I have been talking about this and lecturing at pediatric hospital medicine conferences and PAS for about a decade now. Like, the writing's on the wall for community hospitals, and something's got to change with how we deliver care and how we pay for care in this country. Because right now, there's no incentives for most general hospitals to do anything pediatrics.
No, you shared an article today from JAMA, and then there was another one on the one of the hospital journals where 70 plus hospitals are closing down lines of services, and most of them are maternal infant lines of services.
Yep.
And it's all about funding. When 45% of mothers that are pregnant are on Medicaid, and 52% of the kids are on Medicaid.
Yep.
The hospitals can't afford to give the newborn before this. They can't afford to do the deliveries. They can't afford to take care of the kids in the ER, and they don't want them.
No, again, the finances are geared towards adult medicine and adult surgery and adult procedures. And that's what brings money into hospitals. So if they can get enough of that, if they get plenty of that and they have excess, they're like, okay, we'll do peds and OB. But when things get tight, and obviously things have gotten tight, right? Our healthcare economy is not thriving. It's really struggling. So when hospitals get tight, they say, what are we going to lose? This makes sense. They're not making any money. Why would we keep doing it?
Yeah. Yep. And the quality goes down incredibly. I had a very similar experience as you did at a community hospital in Manassas, Virginia.
Mm-hmm.
And we did exactly what you did. We dabble into the abuse just because we had to, but none of us were trained to do it. But we did have a sedation service. And now it's owned by University of Virginia Health System. And they've closed down everything, including sending letters to pediatricians. Please do not send the kids here for ultrasounds. We don't feel comfortable seeing that. And so now you got to drive in Northern Virginia. You have to drive from Prince William Hospital up to Fairfax Hospital, which is a 30-mile drive. Without traffic, it could be 40 minutes. With traffic, it could be an hour and a half.
Yep. And
it puts you in a really terrible spot because you're covering an office there, and you have a kid. This happened last week. I had a kid with a big cephalohematoma, 5-day-old, 47-day-old. Did not have a cephalohematoma the 2 previous visits in the office.
Ooh.
The parents and the occiput, the parents denied dropping him. They didn't know how it happened. The mother said the kid's irritable. And as a pediatrician, it puts you in a terrible bind because Prince William Hospital is literally half a block walk from the office. But I can't send him there because they'll just discharge him.
Yeah.
So I have to tell the parents, get in a car, drive for 30 miles, and pray that they actually show up.
Yep.
And wait till the morning to get the report from the hospital to see what happened.
Yeah. No.
And it's not good care for the baby. It's not servicing your community because you're not for profit, but you're supposed to be there to help the community. And the community is everybody. That means the children, the moms, the elderly, everyone, not just the hip replacements.
Right.
And as a pediatrician, apart from the personal ego hit, right? This is a program I built, and now I can't even trust them to take care of a kid and scan them. Is the anxiety of how much risk am I taking telling these parents to drive him for 30 miles as opposed to activating EMS? But EMS can't take them to children's. They have to take them right across the street.
And then transfer them.
If the PA or the NP working gets it, that this could be child abuse, shaken baby syndrome. And if you don't intervene, this kid could be dead quickly.
Yeah. And it's really, the data is very clear. There's been some really nice work out of Massachusetts where Massachusetts has some great hospitals, right? It's not like they're lacking for good places, but what's happening is all the community sites are closing and more and more kids are getting transported, and the amount of time it's taking to do it is significant. And the ironic part about all of it is most of those kids either go home from the ER or go home the next day.
Yes.
So they could have stayed in the community if the community had the services.
Yes. And the other sad part is, I prefer Fairfax Children's to Children's National just because of the neighborhood. Okay. It's just, if you're a parent, the last thing you want to be stressed about is what the neighborhood looks like when
Right.
you have a sick kid going into the ER. But it's not fair to dump all these cases. And I don't trust that the community hospital take care of anything. So I have to tell parents, if you have asthma, here's the prednisone, let's do the nabs. If you feel like your kid's struggling tonight, please don't waste time going to the community hospital. Drive, because they're just going to send you home. They're not going to do anything, and you're not going to be able to reach me. So please, just drive to Fairfax. Things that people could help, they don't help. And so the word is dumped on.
Right.
With every single patient. And they have to eat the losses because it is what it is. 50% of the kids are on Medicaid. And it's just not fair to do that to Fairfax or any other children's hospital. And then on top of that, they're swamped with the mental health disorders. And
Right.
they have no beds to transition these kids to. It's untenable. And when we talked to Dr. Paul Offit, he fears another outbreak of measles.
Yep.
What I fear, what if we had another H1N1 epidemic like we did in 2009 that affected mostly children? But this time around, they actually get a SARS-like picture. We don't have the ER capacity.
Yep.
We don't have the bed capacity. We don't have the skill capacity to take care of this. We could actually see in the US, otherwise healthy children dying, waiting in line to get care. Pediatric Executive Development System, or PEDS, is a dynamic, transformative program designed to accelerate the growth and development of the leaders in the field of pediatric entrepreneurship. PEDS takes a hands-on approach to problem solving, addressing real-time situations within your organization. More than a theoretical course, it is a practical platform that accelerates learning. Look at our link on the show notes for more information.
Yeah. No,
Yep.
and last fall we were there with the sort of triple-demic going on.
Yes.
We were transferring kids out of Maryland to Delaware, Pennsylvania, and West Virginia because there were no beds in DC or Baltimore.
Yes.
And that's crazy.
Yeah, but they're waiting in line at a children's hospital.
Yeah.
Where all the specialists are there and all the beds are there and all the services are there.
The outcomes aren't great for waiting anywhere, to be honest
I
with
know.
you. That's the problem, is we know that when there's overcrowding, there's bad staffing ratios. And when there's bad staffing ratios, bad things happen. And
Unfortunately, pediatrics is like the weather.
Yep.
Sometimes it's rainy, sometimes it's sunny, sometimes it's a tsunami. You have to learn to deal with it. But the physicians want everything in a nice schedule, and MBAs want everything on a schedule. And
So I'm in a push
spreadsheet doesn't work.
George, right? Luckily, we don't have wars every year. We only have wars every 10 to 15 years.
Yeah.
Well, we don't dismantle the whole U.S. Army infrastructure once the wars are over and say, we don't need it because we're not at war today. And then tomorrow we have to go to war in Africa. And we don't have soldiers, we don't have tanks, we don't have planes, we have nothing because we just don't need them. It's like the weather. Sometimes it rains, sometimes it doesn't. If we're not at war, we don't need this big infrastructure. That's not true. We need to have a minimal investment in pediatric access.
yeah,
So that we don't need $1 million rooms that never get used. But your formula was very good. I think that what we need right now is a pediatric urgent care that's embedded into the hospital system with an observational ward that can take care of kids from 6 a.m. till midnight. And at midnight, if they can't be discharged, they get transferred to an inpatient bed in the pediatric hospital.
yeah.
Because things have changed. Thank God for your grandfather, right? We don't have to do hepatitis B anymore. They get vaccinated. Thank God for Paul Offit. We don't have as much rotavirus. Thank God for Solfran, because I'm of an age where I let people throw up because we were afraid if we use Phenergan, they get too sedated. Then I have to do a spinal tap because I don't know if he's got meningitis or if it's the Phenergan, right?
Yep.
Thank God for prednisone. I don't ever admit a Kruper. I just put him in prednisone. Thank God for prednisone, albuterol, because I can take care of most asthmatics at the clinic and in their house without ever putting them in the inpatient ward. These are all miracles and the great advances that we did. That doesn't mean that we're not going to have cancer, trauma, or other pandemics that are going to require us to take care of our children. And we have not invested in the infrastructure to make sure that happens. That's not about weather. That's just being silly.
No, and the biggest reason for that is there's no financial reason to do that or imperative to do that, right? All the incentives in hospital medicine are low length of stay, high cost, high reimbursement procedures, and try to move people through quickly, right?
Yes.
And we can do that in pediatrics if we have the staff, but like the average never works.
No.
Average daily census is the death of pediatrics because we could have 12 patients on the unit in the morning, 24 in the afternoon, and 6 the next day, because that's how quickly kids turn over and get
Yes.
better at times. And how do you staff that? You have to invest in it and understand that it's going to cost money and somebody needs to pay for it. And the payers aren't paying for it. The government's not paying for it and the hospitals aren't paying for it.
So it doesn't happen.
It doesn't happen.
So the
Yeah,
children pay for it later, right? The children will pay for it later.
Yep.
Unfortunately.
100%.
Yep. And it's a conversation we have often. And I think the tide is changing. I think even people who are the real academic, whether pediatrician or not, they think money is a dirty word. They don't want to touch money. They don't want to know how their salary is paid. It's just paid because it's paid. And we need to stop being distracted at the national level, the leadership level, and start saying, if there is no money, there is no mission. Because you can be employed by Johns Hopkins. If Johns Hopkins is losing so much money out of their pediatric program, and they got all these general pediatricians that they've hired throughout Maryland, which I don't think is the case, but just as an example, losing money for them, they're going to go, you're all gone.
Yep.
We're Hopkins. The inpatient children's hospital is always going to get referrals. We don't need you, which is different than what the health systems do with internal medicine. I am an internal medicine doctor. They're happy to lose $150,000 a year on my salary because all they need is one hip replacement that I send them and hopefully a heart attack on a young, short 50-year-old.
Yep.
Gets stented, and he's going to have cardiac services for another 20 years of his life through the cardiology department, through the cardiac lab.
Yep.
And that is millions and millions and billions of dollars in revenue. And they're like, yeah, I'll make him a loss leader. All I need is one hip replacement, a knee replacement, and a stent. And I made up twice what I pay him. And that's what I think people don't talk about in pediatrics. As a specialty, we can't be loss leaders because there isn't any way to recoup it. We have to be driven by the fact that we have to answer the question that America doesn't want to answer. What is public health?
Yep.
And vaccinations, as much as I'm a pro-vaccine guy, and I think the pediatricians of America are the heroes of the story, more so than your grandfather and Paul Offit, because they put those needles in those ties. Okay. But that's a public health service that we've never been paid for.
100%. No,
And it's important, but we need to recognize that's not what a pediatric specialist does. That's a public health service that we did for the country out of our own pocket because it's the right thing to do. We need to ask for money for that.
We do not value anything with anybody who takes care of kids in general. And the amount of time that we spend helping families navigate and cope through the mental health system, through the school system, through the whatever other systems they're navigating through, there's no payment for
No.
that. There should be value for that. There's value in what pediatricians do and what
Yes.
they provide to society, and there's no recognition of that. And that's got to change.
And people are going to crucify me. I think they are. And go ahead. You got my email right to me because I hear from all of you. But I think that, for example, the HPV vaccine is costing $250. It should cost $500 a dose because of the amount of money that it's saving into the future. And that money there should be a tariff. I know all of you on the right are going to hate me now, but yes, it should have a tariff. And that tariff should be fed back into the people doing the vaccination and into the pediatric hospitals with a super specialist so that they can maintain their doors open. And they do that in other areas. So when they start talking about, we're not going to have a coal-driven economy, it doesn't matter whether you believe in it or not. Just, we're not going to have a coal-driven economy. They just don't go and shut the coal mines down and support windmills all over the place. They start giving the coal mine and the coal mining unions incentives or money to help them change and to help them maintain the coal mines that are still necessary, because we can't be all wind, all solar, or all nuclear. And we don't have that conversation in medicine. And that needs to happen. And then the next thing we have to answer, and we're not even asking the question, is what are we going to do with Beyfortus?
Right.
What are we going to do with this new medicine that can take care of hemophiliacs? It's $2.8 million. What are we going to do with this new medicine for the kids with sickle cell disease?
Yeah.
Okay. What are we going to do with this new medicine that you can give 14 days infusion and you can delay the onset of type 1 diabetes for, on the average, 36 months? It's $180,000 a shot. Peanuts compared with all the stuff we're spending on it. But how do we do this? How do we do it? First of all, who pays for it? Because the insurance company is not in their benefit. Medicaid's broken. They can't do it. It's not really the employer's problem. The funding should be something like the FDIC. It's a quasi-government institution that takes this money from everybody and puts it for these great miracle drugs that are coming and says, yeah, that's great. This kid's never going to have a sickle cell crisis. It's going to cost $500,000 over the 20 years of his youth. It's going to save $2 million. Great. But we're going to pay up front because we have the funds. And then we're going to take a little bit of that and we're going to reinvest it into the children's hospitals and the pediatricians in the neighborhood so they can continue doing the service they're doing. Because we don't want them to stop vaccinating. We don't want them not to be available. But we're not having these conversations.
No, I'm hoping that the Beyfortus conversation will spur that, because it's a no-brainer that every baby in the hospital should get it before they leave between August and February.
But
It's a no-brainer. But none of the hospitals are going to do it because it's pure cost and they don't get paid for it. So figure it out. Use that as the leverage to figure out a different way of paying for what's needed in a public health realm and valuing prevention, which we know saves money. If we cut down RSV admissions by 80%, don't you think that's going to save somebody some money?
Actually, no.
It's probably not going to.
So this is my biggest problem with Beyfortus. Beyfortus, if every one of the 4 million newborns gets it before they are discharged, would cost about $2 billion. And it would save about $1.6 billion in hospitals because only 80% effective. We are merely paying Sanofi for what we are now paying pediatric hospitals and children's hospitals. And we don't have enough money to play that game anymore. We need to save.
Right.
And so this was an opportunity to save money. So one, it was priced for more than it can deliver. And then again, I sound like a broken record, but the second thing is we didn't ask anything back from Sanofi. They're gonna make $2 billion a year. They can surely spend. Here's for example.
Yeah.
What is $3 million for Sanofi and Beyfortus when they're going to get a $2 billion recurring revenue for the rest of their life? Nothing.
But they will come and give you a sandwich to tell you about it at lunch.
Yeah. No one asked. No one asked because we're so hard-headed that we don't want to talk to industry. Okay. No one asked. But why didn't the gurus, and I'm not going to say the 3-letter word that I don't like.
Don't do that.
George knows what the 3-letter word is.
Don't do that.
Why didn't anyone there say, oh, that sounds like a great idea. How about if you set up a fund, $3 million that gives each practicing pediatrician in the neighborhood $50,000 towards their student loans? What's $3 million to you? Nothing. You keep these doctors practicing. They didn't ask. Maybe they would have gotten $1 million.
Yeah.
Maybe we would have gotten 500,000, but that would have still been 10 general pediatricians.
I think we've got to start thinking outside the box and coming up with better ways of paying for kids' care. Because like you said, everything we do Now the savings might be 20 years down the road,
Right.
30 years down the road.
Right.
And
Right.
nobody has, insurance companies don't care about 30 years down the road. Hospitals don't care about 30 years down the road.
No, should they?
Can't think about next week, let alone 30 years down the road.
But the government, the federal government could.
They could.
They could. Just like they think about the Army.
They need to think of it in those terms, but they
Yes.
don't. They think of it more in other.
Yes. Where do we cut?
Yeah.
Where do we cut? And then the conversation gets really nasty. If you actually look at Medicaid, most of all the money that's spent on Medicaid is on people with special needs,
And adults in
adults
nursing
in
homes.
nursing homes.
Yep. Absolutely.
And you can't honestly say, cut the budgets of the nursing homes to save money. They're already really underpaid.
They need to be separated out. There needs to be a kid plan.
There has to be a different finance solution for children.
Yep.
And it has to be broken down in what is public health? What is these wonderful future medicines that will save us tons of money down the road? But and how do we help those that are going to be displaced by this implementation? And then what George and I think of pediatrics, the ear infections, the asthma patient, what we see in the clinics every day, that for me was much more joyful when there's a lot of infectious disease, because I love infectious disease, but it's not there anymore. But it's still ADHD, but you never know. That's fun of the pediatric emergency room, the pediatric clinic. You just never know what walks in the door.
No, you don't.
You have no idea. Your day might have been boring, runny noses all day for Tylenol prescriptions. And then all of a sudden,
A brain tumor walks in your room as aid, right?
Yep. Then you don't know.
You don't know.
And, do you have any other questions, George? Because I could talk to Scott for another 2 hours. And
Yeah. I'm curious. We were talking about the nobody cares about kids other than pediatricians and finance. Why do you think that is?
It's really interesting because if you look at teachers, they don't get paid anything. Social workers, they don't get paid anything. Children's mental health, no one who does anything with kids. And I think the number one reason is kids don't vote and they don't have a huge lobby that actually gets the resources needed. It all comes down to that in this country is we have not had the conversations, like you said, of how do we make the hard decisions about things that need to happen. And we all know everyone's going to need healthcare, but we have a patchwork system, not an organized system. We know everyone needs schooling. We have a patchwork system. There's nothing organized. And I'm not saying we need socialism, but there's some socialist type things that might help, actually. People need housing. We don't even give people housing. It's really bad.
yeah, I'm as a free market libertarian as you can get. But I understand that the military gets to be funded because if we don't have any military, any crazy person is going to invade us. And I got to pay taxes to maintain that. Do I think that they're efficient and they spend the money in the best way? No. What is better than the alternative? Having Putin invade us and make us all learn Russian. And
they made movies like that.
That
Red
was
Dawn,
good.
remember?
That scarred my childhood.
Red Dawn was like that.
Right. It was in Colorado too. I was like, oh,
Yes.
the road.
And it started in the schools.
But yes, and the federal government is the only one that can afford this long-term investment. That's why the NIH gets all this funding, because they can go for these dreams. And if they don't make it, it's okay. No, the taxpayer lost the money. And they can work on research for 20 years till they get to a solution. And there's no pressure to have a margin. Only the federal government can finance some of these projects. And we need to do it.
I have one more question for you guys. These vaccines, the polio, the hepatitis, those are very inexpensive vaccines. Before this and HPV and the new pneumococcal vaccines, why should they be so expensive?
Our free market medical system seems to value profit over anything else. So everyone's trying to make profit, I think. And there's no incentives for most pharmaceutical companies to do vaccines because they're not long-term big money. It's not like a high blood pressure medicine drug that someone's going to be taking forever. It's a one-shot deal. So they're going to have to recoup their investment. So unless we put more money into investing in the research ahead of time so that they can just make the vaccine and cheap. I also think competition helps too. If there's 5 companies making it versus 1, and we've had such consolidation of vaccine companies that there's really only 3 players right now. And it makes it hard, I think.
So there's another answer to that too, right? I think vaccines are underpriced. I think they should cost more money. They should be on a value-based formula. When you look at the number of hospital admissions the measles vaccine saves, that's the real value of the vaccine. And if that can be given to the pharmaceutical company, to Merck, and a piece of the children's hospital to maintain infrastructure, and a piece to the neighborhood pediatrician to maintain the doors open, I'm all for that.
Absolutely. It's got to be reinvested in the right way,
Right,
not just shareholder
It's
profits.
not just for Merck. And the other answer is, for example, the polio vaccine. Salmon refused to get a patent.
Yep.
He thought it was a public utility.
Both of them. They both said it was utility.
They refused to get patent.
Yep.
And they didn't do this research within the pharmaceutical industry.
Right.
Unlike the hepatitis B vaccine, the HPV pneumococcal vaccine with Maurice Hillman and your grandfather, Merck funded a lot of this research. And therefore, they own the patent. And when they own the patents, they can charge what they want. And there is no way, like when you talk to Paul Offit, 26 years of research to come up with Rototac.
Yeah.
There is no way that you and I could fund a lab on any one issue for 26 years and not make money at it and not get our salaries paid.
Yeah.
There's no way. There's no way, but our grandparents of pediatrics figured out a way in a different time.
Yeah.
That's not possible today. That's just basically impossible to do.
I wonder nobody wants to go into pediatrics anymore.
It's not easy.
It's not easy.
There's a recent article on the Wall Street Journal about 60+% of nursing students and medical students do not intend to do clinical medicine.
Yeah.
They're getting that degree to go on to
consulting.
We
had a medical student rotate through. I'm like, you're doing what? Huh?
Yeah. They're not even going to do a
residency.
They're not going to do anything.
I'm like, you got to be kidding me.
It's just they're experts in this.
Yeah.
And then they're going to go Wall Street or Silicon Valley and sell their expertise and never have to stay up at night, never see a patient, and make a ton of money.
That's short. I don't know. We went into medicine for different reasons.
Correct.
I always learned, do good medicine and the money will follow. If you follow the money, you'll never do good medicine. And unfortunately, today, I think everybody's following the dollar.
Yeah. You have to, because the margins are tight.
Yeah.
But just doing volume or doing great quality doesn't keep your lights on.
Not anymore. It's independent practice is really hard.
Yep.
If not impossible now.
But hospital practice is really hard.
It works till someone says it's not working anymore.
Yep.
Like you said, and someone can turn off the lights on a dime
tomorrow.
Yeah.
So I push back on that. Independent practices it's impossible because
not possible. It's just hard.
Everything's hard. Anything that's good is hard. I live my life in the office of getting rid of stupid. Anything that's stupid that the doctor has to do is stupid. Delete. As Elon Musk said, delete. That's why he was successful. There was so much bureaucracy. Medicine has more bureaucracy than the automotive industry and the space industry. So we have to get out of the stupidness in medicine. But what do? Because of medical legal reasons, because of federal reasons, because of regulations or whatever, we just keep adding. Push this extra button. Push this extra button. Just one more thing. Just push one more thing.
Yeah.
And then the physician just cannot function.
Yeah.
And they call it burnout.
Yeah. So that's the overregulation.
Yeah. Is
a problem. The archaic workflows that were really pushed or shoved down our throats by the Obama-Biden administration called the EHR. That hasn't helped us.
Unless you have PCC, then you're in good shape.
Yes, that's what Chip was
PCC is very good. PCC is very good. Office Practicum is very good. Still computers, and the computers are written by engineers. And engineers are just a bunch of geeks that have some buddy that tells them what to do. And if that's somebody psychotic and just tells them, push this, they're going to build it. And it's going to be more complicated. But you got to build, you got to get rid of stupid. And there's so much stupid fluff.
And that's one of the things, like a simple one, right? Every other professional can have a conversation with you over Zoom, over the phone, over an email, whatever it is, and charge you for their time. Until we had this COVID SARS-2 pandemic, a doctor couldn't charge you for the time spending counseling you unless you came to the office. Yeah. You can tell you can send me a picture of your eye. I can tell it's allergic conjunctivitis. And I can tell you to go get Zadador over the counter, the generic one, and you'll be better in half a day. And you can send me a check for $75. But until recently,
you couldn't do that.
You couldn't do that.
Yeah, but now you can.
If I wanted to bill for that, I had to drag you into the office.
It's crazy.
And that's what you're alluding to. It's stupid that brings no value and just inconveniences the client or the patient. And it prevents the doctors from being financially successful.
They used to prescribe over the phone and do free stuff and consults over the phone and lab results over the phone and on the phone and not seeing patients. And then I wonder why there's physician burnout and nobody makes money. So it's good that they allowed the telemedicine, I think, because is there medical liability for that conjunctivitis?
Oh, yeah.
There's a heck of a lot of it. It's very interesting. My very first medical case on telemedicine other than the ADHD med renewals, I was doing that for a while. But when I turned on sick visits, what do you think it was? It came in as a conjunctivitis. You know what he had? Periorbital cellulitis, which I thought I had him come to the office, ended up sending him to the hospital. It was actually orbital cellulitis. Got admitted to the hospital. But it came in as a conjunctivitis. What do the parents really know? They don't know better, or they ignore it, or their kid can't be that sick. Fortunately, we had the opportunity to bring him into the office. We had late night hours, brought him to the emergency room. The local hospital, they had the pediatrician in the emergency room that realized, oh, this kid needs a CAT scan. And they admitted and they put him into the hospital where the pediatricians rounded, took care of him, and the kid was fine at the end. That's the way medicine's supposed to be.
Yeah.
It's true.
Yep.
Enough of this stuff. Let's go save the world, Herb.
All right. I'm gonna grab lunch with Scott.
All right. Well, it's a nice meeting you.
Nice to meet you.
Yeah.
All right, Scott.
Thank you.
Bye-bye. Pediatric Executive Development System, or PEDS, is a dynamic, transformative program designed to accelerate the growth and development of the leaders in the field of pediatric entrepreneurship. PEDS takes a hands-on approach to problem solving, addressing real-time situations within your organization. More than a theoretical course, it is a practical platform that accelerates learning. Look at our link on the show notes for more information. Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co-host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review, as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.